This is a web-based instruction for nurses and doctors in urological care, especially those not involved in urology on a daily basis. Doctors for Africa and other organizations provide urological care in African hospitals. This instruction is to be seen before urological mission has started and should be followed by live teaching in the first week of the mission. Lower urinary tract symptoms is a problem in about 40% of the older men. There are multiple causes for this complex of symptoms. The major one is benign prostatic obstruction. The term BPH, benign prostatic hyperplasia, refers only to the histopathology and should not be used. There are many different other reasons why you might have lower urinary tract symptoms, like urethral stricture, prostatitis, foreign bodies, urinary tract infections. Symptoms can be divided by filling systems and voiding or obstructive symptoms. You might have an increased frequency of urination. There might be an increased urge of urinations, so you have to run to the toilet. There might be urge incontinence, and there might be excessive passage of urine during the night. Voiding or obstructive symptoms, like a poor stream, unimproved by straining, hesitation on voiding, terminal dribbling, incomplete voiding, residual urine, or acute urinary retention. There might be overflow incontinence due to a chronic retention. About the anatomy of the prostate and the enlarged prostate. Here we see the bladder, the prostate, between the bladder and the urethra. There might be enlargement, as you see here. The prostate has also different parts. There's the peripheral zone and there is a transition zone. In the transition zone, you see the benign enlargements, and in the peripheral zone, the prostatic carcinoma might develop. You can think of the prostate as a mandarin. You have a peel and you have the fruit. Urine comes through the nose to the stalk. If there is an enlargement, there is more fruit, and due to this fruit, you get more tension in the prostate. And then it might become more difficult to pass urine from the bladder through the prostate to the urethra. Diagnostics. We ask for the medical history, do a physical examination with digital rectal examination. There are questionnaires rating the symptoms. We do a urine analysis, laboratory with PSA, that is prostate-specific antigen. We do the creatinine, electrolytes, and a full blood count. Sonography of the kidneys, the bladder, to see if there is residual urine. We estimate the prostate size, the thickness of the bladder muscle, and you might do a uroflowmetry. The uroflowmetry can be done in a sophisticated way, but you can also ask the patient how far he may void. It rates the degree of obstruction. Is there a firm stream or just dribbling? The normal prostate has the size of about a walnut, that is about 20 ml. If there is some enlargement, it might have the size of a small mandarin, but it can also grow up to the volume of an orange. About the treatment options, you can change the lifestyle. That means reduction of the fluid intake. Try to postpone voiding and train the bladder, and don't drink too much in the evening. There might be conservative and medical treatment. You can treat the patients with an alpha blocker like tamsulosin, which reduces the tension in the bladder neck and the prostate. You could give a 5-alpha reductase inhibitor, a very expensive word. It's like finasteride, but it reduces the volume of the prostate. And you can use medication that have influence on the bladder wall, like oxybutynin. This reduces the irritability of the bladder wall. and you can also give combinations. Then you have the surgical treatment. Patients with severe symptoms or unsuccessful medical treatment and patients with recurrent urinary retention, you can offer them a surgical treatment. In smaller prostates, you can offer them a TURP. In larger prostates, an open enucleation. About the TURP. With a tube, the urologist looks into the prostate and the bladder. He can remove small chips by using a metal wire that gets very hot, and in that way you can cut the tissue. In this way you can only remove small chips, and it will take some time, but in the end you will get a nice cavity after resection, and if this is all open, the patient is able to void. Because you only take small chips, this is not the way to treat a large prostate. Larger prostates are treated open. The lower abdomen is opened, the bladder is opened, and the adenoma is removed. It's like an orange. The fruit is removed, but the peel is left intact. The bladder wall is closed again. Sometimes we leave a drain or a suprapubic catheter. There is always a transurethral three-way catheter with the balloon in the bladder or in the prostatic cavity. About the catheter after surgery. In the middle, you see a two-way catheter. There is an opening for drainage of the urine that comes through the small opening at the tip of the catheter, and there is a valve in which you can put water to fill the balloon. On the colored valve, there is always an indication of the amount of fluid that can be put into the balloon. This upper catheter is a three-way catheter. In one, there is the opening through which the urine can flow from the bladder into the bag. 2 is the valve for the balloon, and 3 is the opening for the irrigation fluid. The irrigation comes in a 5-liter bag and runs like an IV drip into the bladder. The urine bag should hang at the bedside with a hanger, and the bag should always be open. It's running in a bucket. The post-operative care. There's always a three-way catheter, sometimes also a suprapubic catheter. Continuous irrigation with normal saline until the urine is clear, or at least overnight. Beware of clot retention. The irrigation must be continuous. If it fails, check for clots in the catheter or clot retention. Do bladder washout by hand with a 50 ml syringe. Removal of the catheter after a TURP is normally done at day 2 or 3 post-op. After open prostatectomy, it will be done at day 5 or 6. About the catheter balloon, it holds 40 to 80 ml of water. See the operative notes for the exact amount of water that is in the balloon. After removal of the catheter, some blood may appear for a period of about 6 weeks. Patients need instruction to drink a lot of water. Some urge to void may exist. This will disappear. About clot retention. To diagnose, feel the lower abdomen. It should be supple. If you feel a swelling, there is retention. First, squeeze the urine drain tube as you milk a cow or a goat. This might mobilize the clot. If it's not successful, you will need to rinse the bladder with a bladder syringe. Do not forget to remove the cap of the syringe. First, pull the plunger to suck the blood and clots from the bladder. Then irrigate with 50 ml saline and suck again. If it is successful, continue until the fluid gets clear and all clots are removed. If it's not successful, call for the urologist. If you can remove all clots, but the urine is still too bloody, you can put traction on the catheter. If you can remove all clots, but the urine is still too bloody, you can put traction on the catheter. If it gets clear, you need to start continuous traction. You put a bandage on the catheter, 1 or 2 bags of saline at the other side of the bandage, and hang this over the rim of the bed. It's like if you have traction on a fracture. After 4 hours, you will need to temporarily reduce the traction by placing the bottles in the bed for about half an hour. If it's still too bloody, then you can restart traction by hanging the bottles outside the bed again. Irrigation related problems. The irrigation fluid bags is empty. You need to pay attention. This is really a very important thing to do. Or the tubes are kinked. The connection between the tube and the catheter is lost. Urine bag related problems is like kinking of the tubes, so you need to use hangers. The bag is full if it's not opened and running into the bucket, and the bag should always be under the level of the bladder. You can also have bladder spasms. The irrigation is clear, the fluid comes from the bladder, and there is still sense of urge to void. Then you can prescribe oxybutynin or buscopan. Here are some examples of proper use of the materials. The bag is on an S-shaped hanger. It's opened, hanging at the bedside and into the bucket. Some examples of plastic hangers, and on the right side you see a bag tied to the bed. What you should not do, put the bag in the bucket. You cannot check if it's running, and it's a risk for yourself as it lays in the bloody fluid. On the right side, the tube was tied so strong that it was obstructed. A wet bed. Always check all connections. Check for stoppers after removal of irrigation tubes. And also check if there is no obstruction of the drainage. Leakage through the urethra alongside of the catheter. Check for obstruction of the catheter, kinking, clots in the catheter. And if everything is okay, then it's a sign of bladder spasm, and you can start oxybutynin. If there's leakage from the wound in open prostatectomies, check patency of the catheters. After removal of the catheter, we need to check if there is post-void residual urine. If there is a suprapubic catheter, you can simply empty the bladder through this suprapubic catheter. If there's no suprapubic catheter, you can feel the lower abdomen and see for swelling of the bladder. You can use ultrasonography with a bladder scan. And the Doctors for Africa have small handheld ultrasonographies in which they can do this ultrasonography bedside too. And otherwise, you might have to send patients to the radiology department to have a post-void ultrasonography done. If there is no or small residual urine, remove the suprapubic catheter and put compressive dressings on the opening after complete emptying of the bladder. If there has been an open access suprapubic catheter, this opening might not close spontaneously. And then there is a fistula that needs to be closed surgically. In the first weeks after catheter removal, continence might be some problem. This will improve. A severe complication is septicemia. There's a severe infection with bacteria in the blood. Patient will become severely ill, has high fever, low blood pressure, and a high heart rate. There is a need for immediate broad-spectrum antibiotics and IV fluids. There might be fluid overload during surgery. In TURP, there is continuous irrigation during the procedure, and that is done under some pressure. Due to resection, vessels are opened, and the irrigation fluid might get in the bloodstream. This can lead to cardiac congestion, so too much fluid in the bloodstream. TURP syndrome is due to water intoxication and reduces the sodium concentration if glycine solutions are used. When in doubt, ask the doctor or the urologist. We all try to arrange a meeting in the first week of our mission. If you have any questions, try to get in contact with us. Please remember, our missions can only be accomplished by cooperation with all local staff and the Doctors for Africa. Thank you for your attention.